Mechanisms of action and evidence-based guidelines. Okay, so in this webinar, I'm going to talk a bit more about the physiological and cellular mechanisms of action and how low-level laser therapy works, and also talk a bit about some evidence-based guidelines that are important with respect to the utilization of this therapy in different medical professions. So as we've talked about earlier, the main target for low-level laser therapy happens to be the mitochondria. And specifically, if we look at the mitochondria, we call it a kidney-shaped organelle in all cell types of the human body, with the exception of red blood cells. And if we look at the 3D shape and internal structure, recall that it has internal cell membranes called cristae that are invaginated, increasing the surface area, which contain different enzymes for different types of cellular reactions. And what we're really most interested in specifically, if we look at the cell membrane, is of course the series of enzymes involved in the cellular respiration or electron transport chain. So the terminal enzymes are shown here. What we're really most interested in is cytochrome C oxidase, or CCO, and ATP synthase. The main target for light absorption for photobiomodulation happens to be the cytochrome C oxidase. In a normal state of a cell, what happens is there's a proton gradient pump occurring in these enzymes, pushing out the protons from inner to outer membrane, which then is pushed back through ATP synthase to convert ADP into ATP, which of course is a cellular energy utilized by cells for their function. In a state of inflammation, for example, an injury process, perhaps as chronic degeneration and arthritis, autoimmune inflammation, other diseases, what happens is it sets up an inflammatory reaction such that there's an internal increase in nitric oxide. Nitric oxide is an important chemical mediator in cells. It has a lot of important positive functions on the cell activity. However, as the concentrations increase, it can actually inhibit the production of ATP. What it really does is it binds much more efficiently than oxygen to copper and iron substrates within the enzyme, within cytochrome C oxidase, thereby inhibiting the binding of oxygen. This, of course, leads to the inhibition or decrease of the proton gradient pump, and therefore leads to lower levels of ATP being produced. If these lower levels are sustained for long periods of time, the cell can be triggered to undergo cellular apoptosis or death, and therefore that cell will die, or at least minimally will function on a very low level state and inhibit cellular activity and growth. What is well understood now is that certain wavelengths of light, the photons of energy, can actually break the ionic bond of nitric oxide to the copper and iron subunits. By displacing that, it allows oxygen to rebind onto the substrates and facilitate an increase in the proton gradient pump, and thereby starting to increase the ATP production. And of course, that means the cell now can undergo activities, everything from gene transcription and increased utilization of different macromolecules, and the cell will undergo a mitosis and normal cellular function. So essentially, this will lead to cell and tissue repair if it's a long-term type of benefit. So in essence, that's the main sort of mechanism of how laser therapy works. This is a summary of what I've just talked about. You can see at the top left here is really just a two-dimensional diagram of cytochrome C oxidase. You can see there's copper, Cu, and heme, HEME subunits I mentioned earlier. So normally what happens is oxygen binds to copper or the iron subunits and facilitates the aerobic respiration. If the levels of nitric oxide become high in a state of inflammation, it actually blocks the oxygen from binding onto the copper and iron subunits and actually slows down the respiration rate. If you add photons on the red and near infrared wavelengths, it actually gets absorbed by this enzyme, specifically at the copper and iron level. And it breaks the ionic bond of nitric oxide to copper and iron, displacing it, allowing oxygen to bind, and therefore increasing ATP production and the respiration rate of that cell. So what one has to understand is looking at the absorption spectrum, or the active absorption spectrum of cytochrome C oxidase, it absorbs preferentially over different wavelengths. You can see here that it goes from 500 to over 1,000 nanometers in wavelength. And you can see that there's a peak with respect to absorption that starts around green wavelength, or 500, into the red, and then it starts to die down and rapidly decreases between 700 to 800. It has another peak between 800 to 900, and then slowly starts to decline again as you approach 1,000 and above nanometers. So the other thing you should be aware of is that blood has a high absorption rate in and around 500 to roughly 600 before it drops off dramatically. And on the other side of the spectrum, water has a high absorption rate of approximately 950 to 1,000 and beyond. So there's actually a window of absorption by cytochrome C oxidase that you can stimulate this enzyme and avoid excessive absorption by blood and water. And those wavelengths are the ones that we target with our therapy, which is roughly 660 nanometers and about 830, 840 nanometers in wavelength as well. So the idea here is to minimize absorption by water and to minimize excessive absorption by blood. Now, there will be some absorption by blood for sure, especially in the wavelengths around 660 or so. However, you'll also be stimulating to a certain degree cytochrome C oxidase, whereas the infrared wavelengths around 830, 840 nanometers basically avoids blood for the most part and is targeting the actual enzyme itself. So those are reasons why we target the wavelengths that we do. In other words, we're trying to target the activity of the enzyme that we know actually that stimulates ATP production in the cell. If we were, for example, to use 500 nanometers, unfortunately, most of that wavelengths would be absorbed by blood, which means that very little would actually penetrate blood into the deeper tissues of the body, and therefore really would have no direct effect on damaged cells. It might have an effect on blood, which is important. However, it's not going to have much of an effect on the tissues themselves. And if we use wavelengths, say above 1,000 nanometers, you're going to target mainly water, and that is not something we really want to do. In fact, almost all class 4 laser devices for surgical applications target much higher wavelengths, like over 1,000 nanometers, in order to heat up water and cauterize and boil water really in the body in order to cauterize and cut tissues or burn tissues. So the main cellular effect I've just mentioned is an increase in ATP. As I mentioned as well, it can actually have an impact on reactive oxygen species. As well, it can have an impact on increasing efficiency of sodium-potassium pump in the cell. As ROS, or reactive oxygen species, increase, it activates an enzyme called nuclear factor kappa beta, which is a really critical enzyme for the triggering transcription of genes involved in the defensive mechanisms of cellular stress. So in other words, by triggering this enzyme to be more active, it actually can help the cell respond to negative stress like inflammation and disease processes. So that's really one of the main mechanisms that's occurring. We also know that light can be directly absorbed by the calcium pump and increase its activity, which is an important function of nerves and muscles. And another absorption point happens to be in red blood cells, where you have a photodissociation of nitric oxide from hemoglobin. This release in the blood causes vasodilation, which in turn causes a greater clearance of edema through lymphatics and smaller blood vessels in and around the inflamed and edematous tissue that's been injured. So all of this are the mechanisms involved in cellular and tissue healing. So this is a summary taken from Michael Hamlin's paper. Michael Hamlin, Hamblin, is one of the probably one of the world's leading authorities on the mechanisms of action of low-level laser therapy. And so again, it's showing you the different absorption points, whether it's the cytochrome C oxidase and the triggering events that occur there, whether it's the calcium channel or sodium potassium channel. These are all points that can be affected by the absorption of red and infrared light. Next, we need to understand what's happening physiologically in the human body. With prolonged exposure, you can increase angiogenesis and neovascularization by increasing the turnover rate of endothelial cells that form new branches or tubes for capillaries in the human body. It also stimulates fibroblasts, which secrete collagen for helping repair of damaged tissues. It also has a role to play in muscle repair and muscle atrophy. It helps muscle cells regenerate and repair themselves, and I'll talk a little bit about that very shortly. And as I mentioned earlier, through both causing vasodilation, but also by being absorbed by white blood cells, it helps control inflammatory modulators that control the inflammatory process and can help reduce inflammation and reduce swelling or edema. And lastly, it will have a positive effect on the cells of nerves, cartilage, and bone to increase their overall metabolism and turnover rate, and therefore it can actually repair bone fractures, cartilage tears, or damage, and damaged nerves as well. So as a review, I've talked a bit about direct and indirect effects of laser therapy. Direct effect is, for example, if you have a damaged cell, in this case a neuron, that damaged cell has increased inflammation exudate or inflammatory mediators that actually damage the mitochondria, as I've talked about earlier, through the influx of nitric oxide. And this damaged mitochondria will eventually undergo or trigger cellular death. If you irradiate this cell with either red or near infrared, which is shown by the NIR, this will stimulate the mitochondria to become more active and healthier, in essence, increasing ATP production and helping that cell thrive and repair itself. Indirectly, or the indirect effect is also a really important way that one can help patients recover from their injuries or their disease processes. Essentially, this works by stimulating both the blood or stem cells and white blood cells and red blood cells of circulating blood. There's been quite a bit of research to stimulate bone marrow to help with stem cell production. However, in humans, it's much more difficult to get much light or really any light through the cortex of the cortical bone. So we have limited applications for this. However, if we stimulate blood, so for example, our dual arrays are stimulating blood quite a lot, especially the red array. This will actually stimulate circulating white blood cells, which then help to control the inflammatory process by increasing anti-inflammatory mediators and decreasing pro-inflammatory mediators, and therefore helping to accelerate the inflammation process. Some of the other indirect effects that have been measured with respect to LLLT includes inhibition of prostaglandins, which is a major inflammatory mediator, decreasing both inflammatory and anti-inflammatory and pro-inflammatory cytokines. It also helps to interact with hemoglobin and myoglobin, as I've mentioned, releasing nitric oxide, leading to vasodilation. And as I just mentioned, increasing white blood cell numbers in the bloodstream to have an effect on inflammation. It also plays a role in impacting the release of cortisol, which is a natural anti-inflammatory agent, increases mast cell degranulation, macrophage activity, and also releasing of endorphins and enkephalins for pain control. So you can see that here that there are many different ways that laser therapy can interact and cause indirect effects. Now, I'll talk briefly about how laser therapy can help with muscle repair. Recall that muscle fibers, if injured, as shown at site A here in the diagram, it actually triggers satellite cells, or what's referred to as myosatellite cells. These are essentially stem cells that can turn into new muscle cells or, in fact, help repair the damaged cell itself. there's been quite a few experiments that have actually shown that when you expose muscle fibers to infrared, near infrared, and red light, it actually stimulates the myosatellite cells in a way to increase the capability of these muscle cells to repair themselves. So this experiment was an assay of single muscle fibers in mice, some of which they had as controls and others of which they irradiated with red light in the wavelength of 632 or 0.8 nanometers. And then they looked to measure the number of satellite cells per fiber after the irradiation, and they found that there were approximately 4 times the number of satellite cells compared to the control. So we know that by stimulating muscle fibers with light, it increases the activity and the numbers of these stem cells to help repair damaged muscle fibers. It's also important to understand the fact that low-level laser therapy is a dosage response type of therapy, and that one needs to be clear that low levels are really important to be effective. If the dosaging is too high, you can actually have less of an effect than at lower levels. So really, where a lot of clinicians are very eager to use greater and greater dosages, class 4 laser therapy, those kinds of things, unfortunately, the research doesn't support the use of higher dosages. In fact, nearly all research focuses on much lower levels because of the dosage response scenario. So let me explain that based on this very interesting research. What they wanted to do here was compare the effects of low-level laser therapy with a common non-steroidal anti-inflammatory on the acute inflammation process of Achilles tendonitis in the tendons of rats. The NSAID that was looked at was diclofenac sodium, brand name Voltaren. The tendonitis was induced using an enzyme called collagenase, which degrades collagen in tendons and causes an acute inflammatory process. So we have control or untreated tendons. Then we have the same tendons that were also treated just with collagenase to induce a tendonitis. And then we had the tendonitis that was either treated with either the diclofenac sodium or 1 joule or 3 joules of 810 nanometers infrared light, about 100 milliwatts in total power. Top left shows you a normal healthy tendon. That's a control. I'm sure you are aware that tendons, if you were to take a look at a fresh tendon, it is white, glistening, no signs of inflammation. And then if it was injected with collagenase, it causes it to swell. You can see it's kind of reddish and yellowish and inflamed. So that's an acute tendonitis that you're observing there. Here's the one that was treated over a period of time. I think it was about 6 or 7 days with diclofenac sodium. You can see it's still quite swollen and boggy, quite inflamed, not really much of a change. Over the same time frame, one that was treated with 1 joule of energy, you can actually see that it's almost the same as a control. In other words, the 1 joule of 810 nanometer light over the treatment regime almost healed up that tendonitis and caused a decrease in inflammation. Now, if we look at the 3 joules of energy, you can see that it's still actually quite swollen. It's better than the diclofenac sodium and better than the acute tendon. However, it's not nearly as good as the 1 joule of energy. So in this case, the Arndt-Schultz principle is such that it was too much energy and was not as efficient at reducing the inflammatory exudate as the 1 joule. A really good example, clear example to show you don't want to start too high when you're using dosages. You want to start lower and work your way up if it's not enough. Light therapy can also cause analgesic effects by different mechanisms, by decreasing substance P and bradykinin, as well as COX-2 and prostaglandin levels. It can actually disrupt the flow of axon transport in pain nerve fibers. So you can actually block temporarily, anyhow, the transmission of pain from nociceptor pain fibers. It can also play a role in central sensitization in chronic pain patients, and as I mentioned earlier, helps release endorphins and enkephalins to help with pain control. Okay, lastly, I want to talk a bit about the road to mainstream for laser therapy, over the last 3, 4, 5, or even longer years. But really, it's been short term. We've been seeing a lot of evidence-based guidelines. Recall that clinical guidelines are created with the aim of guiding decisions for diagnosis, for management, and treatment in specific areas of healthcare. As a healthcare provider, you're obliged to know your clinical guidelines as they come out. That's why you want to review and do lots of CE or continuing education courses to know what's out there and what is now considered to be evidence-based to treat your patients. One of these is the Bone and Joint Decade. This was done by the World Health Organization, and this particular one was done for grade 1 and grade 2 neck pain, similar to a motor vehicle whiplash. And they looked at the different types of available therapies, and they concluded that there was enough evidence to recommend, and not in any particular order, exercises, mobilization, manipulation, analgesics, acupuncture, and low-level laser therapy. So really, this low-level laser therapy was really the only, you might say, modality in the mix. Ultrasound, interferential current, low voltage, other types of modalities was not considered to have enough evidence to recommend for the treatment of grade 1 or grade 2 neck pain. The Ottawa panel for evidence-based guidelines for rheumatoid arthritis in adults also looked at low-level laser therapy, and they concluded that there was grade A evidence for pain at 3 months, and grade C, which is mild but still significant, for tender joints, muscle force, and range of motion at 3 and 6 months. And the Ottawa panel actually recommended LLLT for patients with chronic RA. The British Society for Rheumatology similarly also looked at rheumatoid arthritis, and they concluded that there is good quality evidence exists to recommend and support the use of low-level laser therapy for patients with RA. The American Physical Therapy Association put out guidelines on the treatment of Achilles tendinopathies. This was back in 2010, and they looked at all the different interventions and the evidence based on the gold standard of randomized control trials. The top 2 most evidence-based therapies were eccentric loading exercises and low-level laser therapy, followed by ionotophoresis, and much weaker evidence with things like stretching, orthotics, manual therapies, taping, heel lifts, and so forth. So this is a really good evidence to suggest that it's very beneficial in patients with tendinopathies. I mean, this is for Achilles, but you can imagine that it would have the same effect on other tendons, whether that's rotator cuff, biceps, or other tendons in the body. The British Columbia, out in the west coast of Canada, also put out a task force on elbow tendinopathies, and it had very similar conclusions with respect to exercises and laser therapy for tennis and golfer's elbow, with a much weaker form of evidence for other types of treatment. This is Roberta Chow. She's a medical doctor and researcher, PhD, out of Australia. And she was a family doctor, or she is a family doctor, and was treating a lot of pain patients, especially neck pain. And she started to incorporate low-level laser therapy into her practice, had tremendous results, was obviously prescribing less medication to manage these patients, and went off to do her PhD. And the culmination of her papers on neck pain and other papers was published in The Lancet, and entitled The Efficacy of Low-Level Laser Therapy in the Management of Neck Pain. And it was a systematic review and meta-analysis with a really high impact factor journal. And this has given us obviously a lot of credibility because of the type of journal it was published in. So again, really good evidence to support the use in neck pain. This one came out fairly recently, and although it's not a specific guideline to use laser therapy, I thought it was interesting because it was one of the rare occasions that the American College of Physicians and Surgeons did not recommend medications or injections for low back pain. In fact, what they recommended was the use of exercise therapy or movement therapies, and they supported that, and even actually supported the use of, say, heat, which was also helpful, and also low-level laser therapy. So again, really interesting that they mentioned this, because previously it would not have been on their radar with respect to the American College of Physicians and Surgeons. The Cochrane collaboration puts out many different reports on utilization of medical interventions. In this case, they looked at frozen shoulder and electrotherapy modalities used to treat it. And they concluded that, quote, overall, based on moderate quality evidence, LLLT is probably an effective adjunct to home exercises in terms of pain up to 4 weeks and function up to 4 months. So the Cochrane review was not able to conclude any other electrotherapeutic modality was effective for frozen shoulder. So that's really impressive when they looked at all the different things out there, none of which they felt were even remotely effective, and yet gave really high grade, a moderate grade for low-level laser therapy and adhesive capsulitis. Okay, that's it, and thank you for listening in.